So it's a crisis. Now it's a crisis. It's not where, let me just say this. The earlier you intervene, the less damage has been done. We used to think you had to hit rock bottom, right? You got to hit rock bottom before you get better. Not true. It's not true. The elevator will keep going down, but you can get out at any floor. You can get out before you lose your job. You can get out before you lose your marriage. Okay? So early intervention is the key, and the earlier, the better. I think this is such a powerful example of an early intervention. These are the percentages of 12 to 17-year-olds who have used substances. Now this is simply looking at dinners. How many family dinners does the family sit down for together? And you can see that all they did is they said, okay, you have 0 to 2 family dinners per week, or you got 5 to 7. They don't tell them what to talk about. They don't tell them how long to sit down. All they tell them is have dinner together around that dinner table. You can look, substance abuse rates much lower. There's an early intervention right there. Okay, so a little true false. True false, addiction is a chronic, relapsing, and treatable disease. True. Drug abusers and addicts should be able to stop taking drugs if they're willing to change their behavior. You know, not always true, right? A lot of people can, but there's a good number that cannot. They really are quite miserable in their addiction, right? Drug abuse and addiction is strictly a social problem. Obviously, that's false. It's a biopsychosocial, spiritual, and a financial problem. Addiction does begin with drug abuse, but it's not just a lot of drug use, right? Drugs interfere with normal brain function. It has long-term effects on brain metabolism and activity. Changes occur in the brain that lead to this compulsive drug craving, and treatment is necessary. One thing I can tell you is people in treatment do better than people not in treatment. Plain and simple. Those addicted to drugs suffer from compulsive drug craving, drug seeking, and use. Not everybody can just quit, but they can learn to control their condition and live normal lives. One thing about abstinence versus sobriety. Abstinence does not equal sobriety. Abstinence does not equal sobriety. Sobriety equals abstinence plus the recovery work. You've got to do that psychological work. How did I even end up here? What happened? Why did I start using cocaine? Etc., etc. All that work has to be done. Abstinence plus recovery equals sobriety. So, some principles of treatment. No single treatment is appropriate for all individuals. Treatment needs to be readily available. This is obviously one of the big problems. And you know what? Somebody who's been using opiates for 8 months doesn't have a single dime really left, and they're prostituting to support their habit. It's tough. They really, to start paying that private doc, right? Preferred behavioral health or OSHA mental health, right? I mean, we need more services, and I know they're working very hard to create more services available. But some of these waiting lists are months long, right? So, effective treatment, so treatment needs to be readily available. Effective treatment attends to multiple needs. Remember, the biology, the psychology, the social, spiritual, etc. And the 3 months seems to be a really kind of a critical number. People who get to 90 days. That's why this whole 90 meetings in 90 days, because it's not a random number, right? 90, they want you to get to 90. Individual and or group counseling is absolutely critical, are critical components. The detoxification is only the first step, right? I mean, when I was also at St. Barnabas, unfortunately, it was somewhat of a revolving door, because you detox them in 4 days, which is absolutely, on some clinical level, ridiculous. Well, guess what they're going to do? They're like full on in withdrawal when they leave. They go get high, So we need that longer term treatment. And again, unfortunately, the insurance companies and the way it's all set up now, they don't approve rehab too easily, right? They don't give you 14 days, 28 days, even that too easily. 20 years ago, you could actually stay for 4 months and 6 months, but that's not the way anymore. The only way really that is if you can pay out of pocket, And now you're talking what? $15,000 a month, 20? I mean, come on, who has that kind of money, right? So usually recovery requires multiple episodes of treatment. So you got to keep that in mind, right? So when you go to that same house call and you've been there 8 times already in the last 3 months, I'm using kind of an extreme example, but to make a point, keep that in mind, that it's not that easy, right? They really need repeated, multiple episodes of treatment. Now, we talked about what a dual diagnosis client is. We talked quite a bit about addiction. Any questions related to those areas at all? Okay, I'm going to move on. The next thing I want to talk about is motivational interviewing, and I want to teach you some skills, give you at least the overall bird's eye view on what motivational interviewing is. What is motivational interviewing, right? They basically found that if you beat somebody over the head and you try to tell them what to do, it doesn't work. It doesn't work, right? So they developed this style to motivate an individual to make a better choice, And essentially, so it's an interpersonal style of interacting with somebody. It is a subtle balance of directive and client-centered components, right? So it's a guiding philosophy. Like, you know what, let's understand this together. Listen, by default, when they walk into the office, they know I'm the doc, right? I don't need to tell them that. I don't need to throw that around at all. In fact, I talk to them just like I'm talking to the neighbor, right? I say, hey, listen, you got to be unhappy. Your life is falling apart. This couldn't be working for you. And they say, God, oh my God, it absolutely is not. I've wanted to stop. I've lost my kids. I just can't stop. And I need your help, right? I need your help. So the big thing about motivational interviewing, it helps explore and resolve the ambivalence. It helps absorb and resolve the ambivalence that these individuals have. And I'm not saying everybody's ambivalent. Obviously, the dealers, you know, or some, let me just put it this way. There are individuals that have no, readiness for change. Like that is also something to keep in mind. That everybody, that there's a, how ready you are for change. You may be ready on Monday and make that phone call to the doctor and say, okay, can I get in today? And, and the doc says, no, I'm full. By Tuesday, they're getting high again, and now a month has gone by, right? So the readiness of change is a shifting product. So it's really important to capture that person when they make that call. So I make a tremendous amount of effort, my staff and I, to when we get that phone call, get them in. Get them in through that door. Because if you can engage them, they're on their way. At least that first step, right? So it's really motivation and change. It's elicited from them. It's their task. You want them to talk. So direct persuasion is not an effective method for resolving ambivalence. It doesn't work, as we all know, right? I was just talking about the readiness of change being a fluctuating product. So it's this therapeutic relationship, right? A lot of times, like, doc, I messed up last week. And I really try to create an environment for people like, hey, listen, I'm here to help you. I'm not here to penalize you. I'm not here to punish you. I'm here to help, right? So if you tell me what's going on, I can help you. But if that drug screen comes up positive and you didn't tell me, we got a problem, right? Now, I don't know if I want to keep you in my practice because I'm much more interested in this person over here who is serious about getting and staying in treatment. So I put that out there, and more often than not, they come forth. And of course, it's not always true. And anyways. All right, so the therapeutic relationship, very important. Oops. What is motivation? What MI is not, right? What MI is not? Arguing is not motivating, right? Direct advice without the person's permission. A lot of times I'll say, hey, John, or Cindy, whatever, do you want my input? Do you want some feedback? Because especially if I know I've been talking to this person a few times, I don't think they're hearing me. I've met them a few times and they're still, do you want some feedback? Getting them to say yes opens their ears up in a different way, right? So what you want to do is you want to step out of the authoritative and expert stance. Listen, the police officers in here, you walk up to a person's car, they know you're the cop. There's no question about it. There's a squad car about it. So, in physicians, in all areas, some of us, we throw that around more, and some of us, we throw it around less. But, throwing it around that authoritative expert stance they get passive. Then all of a sudden they shut down and they get scared, as the speaker before me was just saying. They don't know what's going to happen. They don't know what exactly is going to occur. And you don't want them in a passive role. You want them talking to you. You want them to open up and tell you, yeah, you know what, I got some weed in the car. You know, I just want to be up front. Now, how often does that happen? Probably not that often. But my point being is, once things are getting heated, it's much better to try to cool it off, as I'm sure all of you are aware. Again, what MI is not, if you're doing most of the talking, that's not the motivational interviewing technique, right? You want them, you know, to also be talking. I stay away from labels, right? I stay away from the word addict, believe it or not. I know they're addicted, right? I don't need to throw that in their face. And in fact, they're a lot more than somebody who has an addiction, right? They're also a mother, a father, a brother, a sister, or a union carpenter, or a professional, etc., right? They're a friend, they're a human being. So I try to stay away from labels, and surely I try to stay away from this punitive approach. Again, it doesn't work. The last part of my talk I'm going to focus on is psychiatric medication review. It's really, I want to just explain to you the next 5-7 minutes. I'm going to leave about 5-7 minutes after that for answering any questions. It's just, what are the big classes of meds that we, in general, are talking about? I don't know why it just went a little dark, but that's okay. Antidepressants, right? Obviously, somebody who's depressed. Interestingly, even though they have the word antidepressants, we also use them with the anxiety category, right? So we've all heard of SSRIs, right? SSRIs like Zoloft and Prozac and Celexa and so forth. SSRI, selective serotonin. So serotonin is another transmitter, just like the dopamine involved in addiction.